Welcome to our live webcast, Neuromodulation, Indication, Approach, Complications, and Outcomes. Thank you for joining us tonight. My name is René Pescora. I'll be serving as the moderator for this webinar. I'm also the program director of the Pain Medicine Fellowship at the University of Florida. I'm also very proud to be joined by our speakers tonight. It's Dr. Bautista. He is an associate professor, Department of Anesthesiology and Perioperative Medicine, and he's also the Pain Fellowship Program Director at the University of Louisville. We're also joined by Dr. Patel. She's an assistant clinical professor at the Hofstra Northwell School of Medicine, and she's also the program director of their ACGME-approved Pain Medicine Fellowship. We're going to be joined by Dr. Mora. He's an assistant professor, Department of Anesthesiology, Division of Pain Medicine here at the University of Florida in Gainesville. And we'll be joined by Dr. Panjatone. He's an assistant professor, Department of Anesthesiology and Critical Care. And Louis, Zuri, and again, welcome for tonight. And I think we'll start off with the first presentation of Dr. Bautista about the indication for neuromodulation. Please feel free to place any questions using the Q&A feature at the bottom of your screen. We'll be answering all the questions at the end of all four presentations, or I think we have, 4 presentations. Again, welcome and a happy new year. And we'll start with Dr. Bautista. Thank you.
Well, thank you, Dr. Pescora, for that nice introduction, and welcome and happy new year to everybody. So tonight, I'm going to talk about indication for neuromodulation. There's a lot of interface between my talk and the other people's talk, but I will let them expound on the complications and other things related to that. I have nothing to disclose related to this topic. And my objective for this lecture is to discuss different indications for neuromodulation. And also, I want to review some landmark papers for each indication that is currently out there. And of course, I want to share with you what the insurance companies are looking for you to be able to get these technology approved. So it is customary that the first thing that we do is to find a diagnosis to our patient. What is actually causing this pain for us to be adequately managing their pain syndrome? And once we're able to do so, we formulate some treatment plan. We first start with some conservative management like physical therapy, trial of NSAIDs, and over-the-counter pain medication. And then we move up the ladder if we feel like these medications are not helping. We offer them nerve blocks. Sometimes our nerve blocks is not sufficient or it's not lasting long enough that we offer them some neuroablation therapy, surgery, or the neuromodulation treatment that we have, that is spinal cord stimulation or intrathecal drug therapies. So the International Neuromodulation Society defines neuromodulation as any alteration of the nerve activity through a targeted delivery of electrical stimulus or chemical agent that's specific to neurologic sites in the body. And the goal for neuromodulation is more than relief of pain, is restoration of function, that these therapies will allow them to be able to adequately do their daily activities and with decreased pain. Not only that, some of the neuromodulating therapies will allow them to have normalization of their bowel and bladder function. Some neuromodulating therapies would address their tremor and decrease the amount of tremor that they're having. One good thing about neuromodulation is that it is reversible and it's minimally invasive. That means to say that for some reason, the patient does not require it anymore, either due to loss of efficacy or the patient doesn't need it. It can just be easily explanted. So as you can see, you can stimulate any type of neurons in your body, and that is neuromodulation. You can use deep brain stimulators for Parkinson's, a hypoglossal nerve for sleep apnea, spinal cord stimulation for pain, and all the nerves that you can think of with the use of peripheral nerve stimulation. The FDA has specific indications for neuromodulation, and in this slide, it shows you the FDA-approved indication for its use for tremors, focal onset seizure, OCD, pain and depression, and some investigational use with exemptions such as focal epilepsy, traumatic brain injury, and spinal cord injury, etc. However, tonight we're going to focus on current pain indications, and that is where our spinal cord stimulation, intrathecal pain pump play in, and it includes failed low back surgery and neck surgery, CRPS, ischemic disease such as refractory angina and peripheral vascular occlusive disease, pelvic pain and incontinence, malignancy and spasticity. I would not discuss on refractory angina since it's not FDA approved here in the US. Let's go about talking about intrathecal pain pump. So we routinely use these pain pump for patients with a history of cancer because they were not able to tolerate their opioids, or we keep on increasing their opioids. That's why we offer them intrathecal pain pump. However, it can also be used for non-malignant pain, wherein you have some neuropathic pain, and you can use ziconotide for that. For spinal cord injury patient, you can use baclofen, and for basically any type of chronic pain, that you can use opioid, local anesthetic, and clonidine. So for insurance to approve your pain pump, you should have the appropriate diagnosis, and it should be either a neuropathic pain, nociceptive pain, or mixed pain. Again, as I've said a while ago, cancer pain is the most common utility for pain pump. But if pain is chronic and progressive, and you feel like you will be able to decrease the amount of oral opioids that patient has been using, then a pain pump may be your best choice. So you have to document that the patient failed to achieve analgesia with conservative non-pharmacologic management. They are either refractory or intolerant to orally administered analgesic, and corrected treatment addressing the pain generator is not warranted. However, you have to also know that there's absence of surgical contraindication to implanting a pain pump. Next, we go to the spinal cord stimulation. So most commonly, we use spinal cord stimulation for the treatment of radicular pain or persistent pain after surgery. And currently, they have found out that we can use spinal cord stimulation for axial neuropathic back pain. So let us review some trials that has been out there. The first one is this landmark paper by Dr. Kumar and North, and they did a randomized trial of 100 patients with persistent radicular pain following surgery for a herniated disc. And they have found out that spinal cord stimulation is associated with more than 50% pain relief compared with conventional medical management. So recently, like the study on a closed loop spinal cord stimulation system, they have found a pain relief at 3 and 6 months. And the mechanism of the closed loop SCS system is still being explored to date. Although one likely hypothesis is that the ECAP feedback that controls the stimulation may minimize recruitment of A beta nociceptors and A delta fibers during the daily use of SCS. So this study is one of the biggest study out there on spinal cord stimulation, the STANZA trial done by Dr. Kapural. And they have found out that the use of high frequency stimulation showed improvement of persistent radicular pain for patients who had failed back surgery syndrome. So during this time, they have found out that the benefit for primary axial back pain is less clear. But later on, they did some study that I'll show later on that they found improvement even for chronic axial low back pain. So in the recent study published in Pain Medicine in 2020, 25 SCS candidates with low back pain, Dr. Fishman and Dr. Vallejo found out that using a multiplex differential targeted programming, that means to say different frequency, different amplitude, and different pulse width, would provide more than 80% relief compared to a standard programming, which will only provide 50% relief. And this is just a feasibility study, and it will require more robust study to actually prove its utility. But again, this is a start using a differential target multiplex spinal stimulation programming. So in this prospective trial by Dr. Al-Kaisi, they evaluated the long-term effectiveness of 10 kilohertz frequency with chronic axial back pain. And they have found out that using high-frequency stimulation in this subset of patients would provide improvement in disability, quality of life, and reduction of opioids in 36 months. So what are the insurance companies looking for? So you have to prove medical necessity. Definitely prior lumbar surgery would get it approved easily. Chronic axial neuropathic back pain may require a lot of peer-to-peer and a lot of documentation on our part to prove its utility. The pain should be more than 6 months and refractory to treatment with impairment of ADLs. And the patient is not a candidate for additional surgery. In my practice, before I even proceed with spinal cord stimulation, I always refer them to surgery or spine surgery or neurosurgery to document that they are not a candidate for any type of corrective surgery. And you have to document that they failed more than 6 months of conventional multidisciplinary medical therapy that includes NSAIDs, that includes activity modification, physical therapy, and home exercise program. They should be also cognitive enough or aware enough to be able to handle spinal cord stimulation, and they should pass their psychological evaluation. You should also document that there is no untreated existing drug or alcohol dependency for a minimum of 60 days, as confirmed by lab testing. So recent studies have shown the utility of spinal cord stimulation for peripheral diabetic neuropathy. So what's the data behind that? So the Sensa PDM peripheral diabetic neuropathy trial showed that the use of high frequency in comparison to conventional medical management showed an improvement of pain in more than 6 months. So for peripheral diabetic neuropathy, what are the insurance companies looking for? Definitely, you should have a diagnosis of diabetic neuropathy, and they should fail conservative management or tried at least 3 classes of the medications that include anticonvulsants, antidepressants, opioids, and other pharmacologic agents. So chronic regional pain syndrome is one of the pain syndrome that would be of utility with the spinal cord stimulation. So one of the earlier trials done with CRPS, they have 36 patients randomized to receive physical therapy alone and spinal cord stimulation with physical therapy. This is an intention to treat analysis. And the group assigned to receive spinal cord stimulation with PT had a mean reduction of 2.4 in the VAS score in 6 months compared to PT alone, which just provided 0.2 decrease in VAS scores. So that means to say that the use of spinal cord stimulation for chronic regional weight syndrome is beneficial to these type of patients. So in this study by Dr. Van Cleef and al., and they followed the patient up in 2 years, showed utility of spinal cord stimulation on chronic regional pain syndrome. In a retrospective review chart by Dr. Michael Stanton Hicks and his group found that the use of peripheral nerve stimulation would improve functionality in patients diagnosed with complex regional pain syndrome. So for CRPS, what are the insurance companies looking for? So they have been seen by a pain management specialist for more than 6 months, and they should have a diagnosis of CRPS. That means to say more than 2 of the following symptoms limited to one extremity, that they have allodynia or hyperalgesia, and all the signs and symptoms of CRPS. The pain should also be refractory to any type of medical treatment, and they have failed PT and NSAIDs. And similar to other indication, they should have passed psychological evaluation, and they should be cognitively able to manage their SCS with no untreated or existing drug dependency. So how about visceral pain? So Dr. Kapural and his group put the spinal cord stimulation at the level of T5 and T6, and they have found out that patients with abdominal visceral pain would more than likely have a decrease in VAS scores after 6 months post-implant. How about pelvic visceral pain? So Dr. Hunter and Deere published this study, and it's mostly confined to case reports. And they have tried to target the pelvic pain by doing 3 different neuromodulation strategies. First, they put the lead at the level of the conus at T10 and 11. The other one is a sacral nerve stimulation, and the other one is a retrograde stimulation. And they all 3 have shown that it has improved functionality and pain in patients with pelvic visceral pain. However, to date, we still need a robust study that shows efficacy of neuromodulation for this type of pain syndrome. So how about insurance? To date, it's very, very difficult. And I have a couple of patients that I have tried to do it for pelvic visceral pain. I have 50-50% chance. Again, it's all about documenting that you have tried all the injections, all the medications, and this is the last resort for them. Let's go and discuss about dorsal root ganglion stimulation that Dr. Patel really loves. These are all the indications for dorsal root ganglion stimulation. You can use it for trunks and limbs, for the foot. You can also use it for axial low back pain, discogenic pain, phantom limb pain, postherpetic neuralgia, of course, CRPS. Dorsal root ganglion can also be used as salvage treatment for SCS and pelvic pain. So this is one of the biggest trial for dorsal root ganglion, the ACURATE trial. It's a pivotal prospective multi-center randomized trial, and they had 152 subjects diagnosed with CRPS or colsalgia in the lower extremities, and they have found out that DRG stimulation provided a higher rate of treatment success with less postural variation in paresthesia intensity compared to SCS. So the other type of neuromodulating strategy is the use of peripheral nerve stimulation. So peripheral nerve stimulation, you can stimulate all the nerve that is outside the neuraxis. If you have a target peripheral nerve, you can definitely use PNS for that. So it has been shown to be effective in neuropathic, musculoskeletal, and even visceral pain. And you can use peripheral nerve stimulation in isolation or concomitant with SCS as a rescue. So most often it has been used in facial pain patients that you align the nerve stimulation in the nerves, such as the supraorbital nerve for headache pain. So we all know that axial back pain, we're doing radiofrequency ablation. So given the minimally invasive and non-destructive nature of peripheral nerve stimulation, this study by Dr. Deere have shown that percutaneous peripheral nerve stimulation may provide a promising first line of neurostimulation option in patients with chronic axial low back pain. So what is the future for neuromodulation? Again, as you can see that the IPG is getting smaller and smaller. It's easily implanted and removed, and it's highly targeted. we just have to have some more basic science that showed or would give us an understanding of the neural circuitry. And with the advance of my medical engineering, I think it is on its way. So in conclusion, you have to have a disease-specific criteria for spinal cord stimulation. Before you're proceeding with the implant, you have to have a documented pain reduction of at least 50% for at least 3 days. And when you decide to move forward with the implant, you have to use the same device for the trial. There are certain occasions that you do competitive trial if one stimulation may not be beneficial, so you can switch to other form of stimulation. Thank you.
Alex, thank you very much for your wonderful presentation, starting off the indication about neuromodulation, which is actually a very broad field. Whenever we sort of manipulate nerves or nerve central system structures, it's not just spinal cord stimulation, which would narrow it down. So thank you very much. And I think we're moving forward to the next presenters, Dr. Karan Patel. And there she is. And I think the audience is all yours, and you will talk about the approach to neuromodulation. Thank you very much.
Okay. Thank you all for joining us tonight. And, this is one of my favorite topics. I always say that, if I had children, my first child would be spinal cord stimulation, and my second child would be dorsal root ganglion stimulation. So tonight, I am going to focus on spinal cord stimulation because, I only have 15 minutes, and to give you everything you need to know, I thought it would be best for us to focus on one therapy. So first and foremost, I think the very first thing you need to do is to think about what you're going to do before you either go to the OR or to your procedure room. So the shape of this talk, we're going to talk about how to trial patients, and then we're also going to talk about some specifics to implanting spinal cord stimulation. So what should you do before you go to the OR? Well, you certainly need to know your patient. You need to know their pain patterns. You need to know if they have had a trial and you're about to go for implant, you need to have the trial notes. You need to remember and know exactly, where the leads were positioned when you left them on the table, right? And then what I like to do when I do my lead pulls is also take a fluoro if it's available so that we can see if the leads migrated and what the effect was of where we were programming. And that I really encourage all of you as you move into, for those of you who are fellows, as you move into the second year of your fellowship, to start doing that, because you're going to learn a lot more about the capabilities of where you're stimulating. If it's a patient who's going for trial, you want to understand what their MRI or CT scan shows, if there's central canal stenosis in any particular areas, or if there's foraminal stenosis, if we're talking about dorsal root ganglion stimulation, that's more relevant. And you want to have had a discussion with the patient ahead of time about their IPG placement. You want to ask them, what side do you sleep on? Where do you, if for men who carry their wallet in their back pocket, you may want to ask what side do you carry your wallet on? And that may help you decide with them where to place their IPG. You want to understand if they have any antibiotic sensitivities or allergies. And you want to work with your anesthesia colleagues, right? Many of us are anesthesiologists on this, and we ourselves take these considerations into mind, but working with anesthesia colleagues, we need to think about, is this a patient who, can tolerate sedation, or is this a patient who we should do under general anesthesia with neural monitoring? And then you want to meet with the electrophysiologist if you're new at a facility and explain to them that typically, this is what I recommend, and what our best literature shows is that if we're doing anything in the thoracolumbar space, we really want to be looking at least SSEPs and EMGs. And certainly if you're in the cervical space, you want to do SSEPs, EMGs, and possibly even motors. And one may even do motors in the thoracolumbar spine if they feel necessary. So what should you do before incision? Well, you have to know your staff. Some of you who are pain fellows who are watching this, a few months from now, you're going to be new attendings at possibly new institutions. And so you really have to understand, have a good communication established for your first trial or implant with the circulating staff. You want to explain what instruments you're going to need to use, what sutures you'd like to use, where you want the C-arm positioned. You want to have a good conversation with the X-ray staff in terms of, how are you describing cranial caudal tilt? Is it angle toward the head, angle toward the feet? What kind of language are you going to use so that you're on the same page? You want to make sure that, there is radiation protection. A lot of times, I remember my first implant that I ever did, I was roaming around the hospital looking for lead that wasn't locked in, to a specific person's like hub. And then in terms of positioning, you want to understand what is available in terms of OR beds. I feel like every time I'm doing an implant, this is a consideration, whether it's for spinal cord stimulation, dorsal root ganglion stimulation, intercept, kyphoplasty, mild procedure. Each of these procedures has an optimal bed. So you want to understand what's available. Is this a Jackson frame? Is this a Jackson with a flat pad that you want to use? Do you want to use large jelly rolls? Do you want to use a Wilson frame? And you want to make these considerations with regard to the patient, right? Do they have a large belly? Do they have extreme kyphosis? All of these things have to be taken into consideration, both in the OR and in the procedure room. So typically, when we talk about placement, right? So this is relevant with both cervical and lumbar. And so for lumbar, typically we're talking about entering the L1, L2 interspace. And then the leads for the upper extremity, typically C7, T1. Now, part of that pre-op workup is that you're looking at their imaging and you want to see where the optimal entry point is. You may find that the spine is highly arthritic. And so you may decide that, in for cervical placement, you want to enter T3, T4 because the opening is much larger. And that's perfectly reasonable. But have this thought, look at the imaging, look at the patient's spine and make these considerations. In general, what is advised is the paramedian interlaminar approach. Typically, that is starting at one pedicle below. Well, we'll look at the next slide here, if I can get to it. And so what you want to do is you want to start if we're talking about a patient who we're trialing from the skin, and we're talking about, in this particular image here, we're entering on the left side. If we're looking at the pedicle as if it's a clock at the level below, I would say that you'd probably want to enter around the 3 o'clock position on the pedicle, anywhere from the 3 to the 6 o'clock position. And what that's going to allow you to do is to really kind of angle medially so that you're entering, you're able to walk off the lamina and enter into the interlaminar space in the optimal position. So you want to advance the epidural needle, obviously under fluoroscopic guidance, but you want to make sure that you're being mindful of how much fluoroscopy you're using. This is not something you need to do live. This is something you can use with intermittent fluoroscopy and also with feel. As your residency and fellowships have progressed and you've done more epidurals, you're familiar with what walking off the lamina feels like and what that feels like under the tip of your needle. And you need to take that into consideration. What is also important to consider is that lamina is lined by C fibers. And when you have a 14 gauge TUI needle and you're touching down on that, that can be quite irritating to the patient. They may have sedation for the trial. However, when they wake up, if you are searching for the lamina and you're pushing down really hard, the patient's going to have pain, more so in recovery, and that might make your post-procedural programming with them less meaningful. So that's something to keep in mind. You really do want to put as much local anesthetic there as you can. So once you are walking to the laminar edge, you then want to transfer over to the loss of resistance. And I have our fellows use air. Using saline is perfectly reasonable. Remember, the epidural space is a potential space, and that could be filled by either air or any fluid. And so you're looking for that change in the resistance. And once you have that change, we'll talk about ways in which you can confirm it. So what you can do here You can look at a lateral and you can look at your angle of approach. And now what we see on this nice fluoroscopic image is that the angle of approach is less than 45 degrees, closer to about 30 degrees is what you ideally want. And that what we see is that the lead itself is starting to enter the posterior epidural space and looks like it's staying posterior. So that's one way in which you can do it. You can go to a lateral and confirm your placement. You can also use, all of the kits of all the manufacturers have a lead blank, or as we say, a guide wire that you could gently, advance if you didn't want to, expose your lead to extra manipulation, which there are advantages to that as well. The less manipulation, we know there's less infection, less potential trauma to the lead and damage to the lead. So use a lead blank, look at a lateral, and look to see how it's progressing. So loss of resistance, we talked about this. There's one needle that comes in the kit. It's typically anywhere from about 5.5 to 6 inches long, depending on the therapy. There are longer needles that are available for larger patients. You have to know your patient, right? If it's somebody who has been, particularly overweight their entire life, they may, require a longer needle. If it's somebody who has gained a lot of weight later in life, their spine may be more superficial. And so that's something to keep in mind when deciding what needle to use. So ideally for lead placement, the epidural lead, we want it about 2 to 3 millimeters to the left or the right of the same side of the painful region. So say if the patient's painful region is in the left leg, if we're floating that lead, we want to cover the T8 to T10 vertebral bodies, and we want to make sure that that's on the left side. Similarly, if it's a right leg, and lower back, we want to cover T8 to T10. For the upper extremities, typically it's placement between the occiput and the C3 vertebral body levels. If you find there's something that is really interesting, when you are guiding your lead, if you feel that it's kind of almost looks like it's sliding across ice, like it's kind of shifting laterally, that's a sign that it may be anterior. And so what you should do is don't try to float it again. My best advice to you early in your career is just go to a lateral and see if it is staying posterior. More often than not, if you get that kind of lateral movement, you're going to see that it's moving anteriorly. I call that when it's skidding left and right, or it tends to want to skid toward the gutter. That's when you know you need to definitely check the lateral. Even if when you first entered the space on a lateral, it was posterior, it could certainly move anterior based on scar tissue or based on a number of things. Similarly, if the lead placement is too low and you end up closer to the conus, you can get a variety of stimulation. That's when all of our nerve roots are kind of converging and coming in. And so that's where it's least predictable, where somebody's, a lead placement on a particular place that may be 2 to 3 millimeters to the left of center may stimulate something very different from patient to patient. In fact, I could talk about this, but pelvic pain, one of the areas which we were using was conus stimulation for pelvic pain. And one of the challenges with that is that we found that there was a lot of unwanted stimulation in other areas. So here, again, to emphasize the ideal placement, we want it essentially, when you're looking at your fluoro image, you want to make sure that your spinous process is bisecting the pedicles. So you're starting with a good AP view, because we are assuming to the best of our ability that, essentially a good AP view is going to lead to a good physiologic AP. However, we know that everyone's dorsal column or spinal cord is actually tilted somewhat a little bit. So if you start with a perfect AP view where that spinous process is bisecting the pedicles as much as possible, and you may have scoliosis where from level to level that changes, but if you start out this way, this is going to be your best way of predicting how a particular patient is going to stimulate when you go ahead and test, or when you go ahead, if you're using anatomic placement, if you go ahead and turn the device on in recovery. Similarly, cervical is a little different, right? And so the thing to emphasize with this fluoroscopic image is that you really want to the best of your ability, try to find the spinous processes first. And then how I feel I like to do it is I find the spinous process, And then at each level where my electrodes are, I want to see how my pedicles look. And I want to see that my lead is really along as close as possible to that spinous process, either on the left or the right, particularly if I'm placing two leads, which most of the time we are. And then we're bisecting those pedicles. And you have to get used to looking at cervical spines and looking at, you're going to have the mandible that's going to kind of obscure things. Being able to search and find those spinous processes is a very important skill. So, the electrodes can be, how to steer. I mean, this is always one of the biggest things. The first pet peeve I have is when I see fellows or residents like hit down on the lamina, and I'm like, oh my God, that patient's gonna have so much pain post-op. The second pet peeve is when I see people who are steering, they're turning, but they're not advancing. They're just turning, and they forget to advance, or they advance and they forget to turn. It's really together, and it's an acquired skill. But what you also have to keep in mind is that you don't want to do this, with excessive amounts of fluoroscopy. There are some moments where you're going to need to use live, and there's other times where you can use pulse fluoroscopic guidance. And, that these are good times to have discussions with your attendings to get that feedback in terms of, when should we really use live? And then I personally feel that live should really be used if you have an area that you find, there's an obstruction, or you find that you're slipping laterally, or you're slipping to the opposite side. That's where I think the live is really most valuable. And again, you want to get comfortable with looking at lateral images. And you can start to do this even with your basic epidurals. You want to make sure that your lead is staying posterior, and you have a sense of where the thecal sac is. Here we can see kind of the labeled diagram of where the thecal sac is, and then we can look at our angle of approach, and we see nicely that the electrode is staying in the posterior space. Similarly, this is our cervical, and we can see that the lead is staying nicely posterior away from the thecal sac. So the next step, once you have your leads in a good position, it's a discussion you should have had ahead of time with the patient as to whether you're going to do testing on the table or whether you're going to use anatomic placement. There's a great body of evidence to suggest that anatomic placement can be used with a good level of certainty that, we're going to be covering the right areas. Again, really staggering the leads over the bodies of T8 to T10 for the lumbar spine and the lower extremities, and then for the upper extremities from the occiput to C3. So for trials, many people use a nephrostomy tube dressing, others use suture. What's available to me, steri-strips, hypofix, tegaderm. I often tell my fellows that if my practice was burning down, I would first make sure the fellows were evacuated safely, but then I would make sure I grabbed a hypofix, because I really think it's one of the most important things that we have, because it allows me to keep the trials in place. What you want to remember, if you are using the nephrostomy tube dressing, it's pretty large. And so what you want to do is you want to make sure that for those who are obese and have skin rolls, you really want to stretch out the skin rolls, then make sure your dressing is down. Because if you don't do that, and this is kind of a rookie move, the minute they get up on the table, it's going to pull your lead down. And there are plenty of studies that have documented that even despite anchoring the lead with a suture or stitch, there is a chance for about 1/2 to 1 vertebral body migration as soon as the patient assumes the upright position. So, part of that pre-op workup of looking at the spine ahead of time is you want to see where there's stenosis, and you want to see where there's narrowing at various levels. This may lead you to place two leads at adjacent levels on the same side, because you think your angle of approach is going to be more challenging if you do two leads coming from opposite sides. Similarly, you could do two leads placed at the same level, which is the classic teaching. So execute. And what I mean by this, what do you need to know? What do you need? And this is about, implants. Just get this out of the way so I can. Okay, so mark it out. This is one of the first things I do, especially, I do a bunch of DRG implants. The very first thing we do is we mark the spinous process above and below. And, we mark it, the length of it, right, of where we want to make our incision. And then we mark midline. The way I do my particular implants is I make a midline incision and then I underscore on both sides, and then I place my needles. Now, when you're first starting, what I recommend is that you place your needles and then you make your incision around that. And that you allow your needle to protect your lead, and if you're doing DRG, to protect your sheath as well. So mark it out with a marking pen, infiltrate with local anesthesia. You want to use typically a 15 blade 3 handle, and you want to make sure you're using the belly of the blade with a firm fluid incision and using counter traction at the same time. It sounds like I'm, speaking about something that is very simple, but more often than not, people forget when they step up to the plate. So this is what I recommend when you're first starting, for sure, because just because you placed a lead, so for standard spinal cord stimulation during the trial, it might be, ideally it's only a few weeks later when you're doing the implant and there may not be scar tissue. However, it may be actually sometimes up to a few months later when you're actually doing the implant. And if that's the case, there may be scar tissue. So where you enter with your needle may not actually be where you end up, placing your lead. And for that reason, I think you don't burn any bridges by making sure that you place your needle first and then cut around that. So I think it's really important to understand about dissection. So once your needle's in place, you've made your incision around your needle, you want to use blunt dissection ideally as much as you can, because that's going to minimize bleeding and that's going to, decrease your time in the OR. However, knowing that blunt dissection can increase tissue trauma. Sharp dissection, it increases your chance of bleeding, but it minimizes your tissue trauma. So as you do more and as you work with your attendings, pay attention to when blunt dissection and sharp dissection are being used. Ideally, we're using gentle blunt instrument dissection and using the electrosurgical unit in the cut mode. So what do you need? What are you using? Well, essentially, typically it's Mayo dissecting scissors, and these are used for cutting or dissecting heavy fascia or adhesions, and typically for your pocket formation. The Metzenbaum dissecting scissors are used for more delicate tissue. And in general, the longer handle to blade ratio allows for greater control. In terms of forceps, there are different types, the DeBakey and the Adsons. It's important to just become familiar with it so that when you're looking for something, when you need something, you're using the right name. So tissue retractors, similarly, the Wheatlanders in your typical standard spinal cord stimulation kits, there's going to be Wheatlanders of different sizes. There may be one that you use for the midline incision or the paramedian incision when you're holding space to complete your anchoring. There may be a larger sized Wheatlander that you use for any movement within the pocket. Typically, when I'm doing anything in the pocket, if anything, I'm using an Army Navy instrument and having an assistant help when I'm using that for hemostasis or irrigation. Similarly, a skin or a sen or a dental, this isn't often a useful tool when you are placing your anchors because it's a much finer tool. It's also very useful sometimes if your incision, as you get more experience, as your spinal incision becomes smaller and smaller. So this is an art form that is important for both the trial and for the implant. So once you have your lead in the perfect spot, the first thing I say is, okay, let's swap that image to the second screen so that as you are moving your needle out of place, you're making sure that you have an image to compare what you're doing in real time to where your ideal placement is. So you can see if your lead is either, moving inferiorly or has moved more superiorly. Because ideally, once you've done testing, if that's a case, or once you've decided on your anatomical placement, you want to be consistent with that lead placement. So once that lead is in place, you want to anchor it. And as for those of you who know me, DRG, I said, was my second child. And anchoring is a huge game changer in terms of the durability of that therapy. And so anchoring is important both in SCS placement and in DRG placement. And so one way to anchor in general, in kind of the classic way, is taking a silk suture and placing it through the fascia, then tying your typical 3 knots down so that it's adhered through the fascia, and then wrapping that around the anchor, tie an additional 3 knots. That's the most basic. Depending on the design, you're going to potentially modify that. So some anchors are click locks, some of them are, swift locks. There's the injects. There's also, the silastic anchors in the DRG kits. We have a whole anchor method for that, which, we can talk about offline. So creating the pocket, you want to, again, using those principles of incision, using the scalpel, and then trying to find a balance between sharp and blunt dissection. You want to really use, if there is a dummy generator available, I always like to put that on the skin and really map out the maximal width and the maximal length of what I'll need, knowing that I want to make my incision such that 1/3 is above my incision and 2/3 is below, meaning 1/3 toward the cranium and 2/3 before caudally. And typically placement for this can be in the buttock, the flank, the lateral hip or abdomen. And it depends on the patient's movement. It depends on their body habitus, depends on how they sleep. One thing that's really important, as you see that image there to the right of the screen, you'll see the cluneal nerves. And so if you place the IPG too close to the iliac crest, you can irritate the cluneal nerves. And many people, for years and years have described pocket pain, and the number one cause is when this is not taken into consideration. So that's easily something to avoid by having fluoroscopy there, seeing where the iliac crest is and making sure that you're staying away from it. Again, when you're making that pocket, you want to minimize tissue, really trauma, but also you want to minimize tension as well. So you want to be mindful of the length of the leads and the size of the patient. When you're selecting the length of the lead, you want to take that into consideration. Like, where am I putting the IPG? How tall is this patient? Do they have a long torso, a short torso? And ideally, you want to have in the spinal incision, you want to leave a strain loop, or you want to leave some type of extension of the lead, such that you allow for that kind of give when patients are moving. So tunneling, we're doing this with a sharp tip, malleable metal probe that has a plastic sheath over it. And typically you want to use 10 to 30 degrees curve at the distal third, directing it from the midline to the IPG. You want to advance with your dominant hand and palpate with your non-dominant, and then remove the handle and the rod and leave the sheath in place. You may decide to irrigate more so through that, through the actual, the tunneling tubing as well, just to make sure that you're helping to decrease any type of bacterial infection. And so you want to make sure that you're using the tunneling device appropriately. So each company that you use or each tunneling device has a slightly different. So it's important to understand, what is the actual mechanism of it? How do you disengage the handle from the plastic tubing so that you can leave it in place? And you want to tell your anesthesia colleagues when you're tunneling so that they're mindful of what's going on in the field. So once you have your pockets, once you have your midline incision, your leads are anchored. Once you have your pocket, you have allocated for hemostasis, everything is good, and you've tunneled, then you really want to irrigate aggressively. In most hospitals at this time, I think normal saline is kind of the standard. There are, I do use vancomycin powder in my incisions. There's some controversy there, and there's some literature that suggests that, we don't quite know a dosage, if you will, and that sometimes, using vancomycin powder may lead to seroma, but there's no firm evidence for that. There's also antibiotic pouches that are available from some of the major manufacturers of our SCS devices. You want to make sure that you have enough you have the leads coiled behind the IPG. This is particularly very important for those devices that are rechargeable, because you do not want the lead above it. And for those leads that are, rechargeable, you want to make sure that the labeling is facing up. So let's talk a little bit about sutures. You need to understand the differences. So there's natural versus synthetic, absorbable versus non-absorbable, monofilament versus multifilament. Typically, if I'm doing a closure, I'm using 2 ovicrals, then 3 ovicrals, and then a subarticular with monocryl or staples. And again, something to keep in mind is, what is most cost effective for where you're doing the implant and what is most reasonable for your patients, right? If they live very far away, having them come back, 7 to 10 days for staple removal may not be the most practical thing. And so therefore closing with a subarticular monocryl might be more practical. So my colleague is going to discuss with you complications. And my advice with that is that, once you've planned to the best of your ability and you've executed to the best of your ability, you have to recognize and revise complications. And that's equally as important as learning the skills about how to deliver the therapy. So in summary, you want to consider this as the skills that you're trying to acquire is how to plan for the therapy, starting with proper indications and the right therapy for the right indications, understanding the patient, their other comorbidities, executing, knowing what resources are available to you, recognizing any issues, and then revising them. You need to know your patient, you need to have a plan, and always consider minimizing tissue trauma and infection risk, and anticipate that there's going to be complications. Thank you so much.
Thank you very much for the detailed description about the approach to neuromodulation. And I'm sorry, I know it's just a very limited time to touch on such a broad topic. I think, Kiran, you did excellent. And let's move forward to Dr. Moore from the University of Florida. He will talk about complications. I think things we need to address and need to be forward on. And I think if it happens, I think we are well prepared to manage. Juan, the audience is yours.
Well, hello, everyone. So again, Happy New Year. It's kind of like difficult to follow this great two speakers, but I got assigned this topic that is complications. Hopefully, I don't get to scare you guys about neuromodulation. My goal today actually is going to be to try to provide you with some tools and some advices. So this is pretty much a quote that if you learn anything from today, from my presentation, that you can take home with. So an ounce of prevention is worth a pound of cure. So prevention is gonna try to minimize this complication. No one wants a complication for this neuromodulation procedure. Definitely it's not good for you, not good for the patient. And that definitely most of them can be prevented. So this is kind of like the scariest slide. So mainly it's going to be the list of the most common complications that you can have with neuromodulation devices, as Dr. Patel mentioned as well. I'm just going to mainly focus on dorsal column or DIG stimulation. So mainly the one within the spinal cord. So you can divide them either like by time, the ones that are happening just immediately after the procedure, or the ones that just happen way after a few months or so. But the most common way to divide them is the ones that are related to the device and the ones that are just biologic. And the ones that are device related, the most common is going to be the lead migration, followed by lead breakage, disconnection of the leads, over or under stimulation, the battery failure, and as well the failure to communicate with the IPG, either for charging purposes or for reprogramming purposes. Biologic is going to be the most common, will be infection, then it's going to be bleeding, as well thrombotic events, because we as well are asking the patient to stop some of those anticoagulants that they are on, seroma, nerve damage, CSF leakage, and of course post-dural punctual headache, pain over the IPG, and allergic reaction. So let's just talk briefly about some of them. But again, my goal is to mention them, but as well for each one of those categories, I'm going to give you some pearls of prevention. So the device related is the most common. It's even more common than the biologics. It's gonna the lead migration is going to be the most common. It's going to range from anywhere between 13 and 22%. As Dr. Patel mentioned, actually, it usually just happens the second that the patient stands up from the working table. The cylindrical percutaneous lead may have a little bit more incidence of migration than the paddle leads, mainly because of the placement of these devices. And then the patient definitely will have some loss of therapeutic effect. You may have to revise it if the representative is just not going to be able to reprogram the device. Lid fracture disconnection is less frequent, is between 6 and 9%. Usually it just happens when you don't leave that retention loop that Dr. Patel was mentioning. So there's a lot of tension that can fracture the lead. Battery failure is going to be not that common for the non-rechargeable. May as well be that the battery doesn't last as long as they promise, or for the rechargeable that actually they will have some issues recharging the battery, either because they lost contact, or sometimes some of the companies make sure that you ask the reps if the battery can be just placed in facing up where the writing is facing up, or they can be flipped and the patients can charge or not. So prevention, what to do with device-related complications. As the two speakers before spoke, adequate patient selection, that's going to be key, right? So this is an elective procedure. Make sure that you choose your patient correctly, not only for the indications, but as well the risk that you're going to put these patients through, and as well the chances of success. Once you select the patient well, then of course you as well need to know your patient, but as well know the equipment that you're going to be using. So my advice is to know all the companies that are out there in the market. They're going to be really similar, but they're going to have some small differences, and some of them will have small different anchors, different tunnelers. That is going to be just better that you get familiar with them before you go into the procedure. Make sure that you provide adequate patient education, so they can have some realistic expectations, as well they're aware of the possible complications with the devices. So a little bit of reality. So by the ACGME, the fellows here in the audience, you will be required 5 of these neuromodulation procedures to be able to graduate yourself from a fellowship. However, when they did a survey of all of the graduated fellows, only 56% felt comfortable doing a spinal cord stimulator permanent after they graduated. So make sure that you get as much possible time with these cases, of course, mainly in your fellowship program, but as well with the societies like ASRA. And then the other one as well, that is an option, but just be careful with the bias that you will get from them is going to be the industry. Preoperative planning, Dr. Patel already touched upon that. The IPG location, it depends on the body habitus of the patient, or as she was mentioning, where the wallet is. Definitely the patient is going to have to carry this for years, so it needs to be comfortable for them. Don't put it deeper than 2.5 centimeters. Main reason is that even if it is a non-rechargeable device, the rep will need to have communication with the device. So if you put it too deep, then they may not be able to recharge or to communicate with the IPG. Of course, as well, to prevent flipping, see if you can do an anchor stitch. Each one of the IPGs have two holes that you can use to anchor the IPG as well to the deeper layers. And of course, if you think that this patient definitely is not going to be a patient that, or the risk of migration is just too high, consider to refer that to your neurosurgery colleagues for a paddle lead. Regarding anchoring, as Dr. Patel mentioned, there are different methods. Make sure that you use a non-absorbable suture as Ethibond, and the click or the mechanical anchors may be a little bit better at preventing migration. However, if the patient is too slim and then you have just too few or not too much tissue to work with, then those mechanical anchors may be just too bulky, and then you will need to use the one that are a little bit more flimsy and slim. So that's for mechanical complication. Now we'll go for biologic complications. As I mentioned, infection is going to be the most common. Of course, these are horror pictures that hopefully you don't get to see in your career. But the truth of the matter is that the incidence is about 2 to 10% in the literature. This is a really good picture for one of the latest NAC guidelines that was published last year in January. Actually, it's about surgical techniques. So there are going to be 3 types of infection. The first one on the top of the screen is going to be the superficial infection. You're going to see some erythema and maybe some a little bit of superficial wound issues. So that is just not going to include the pocket itself. Some of the times this can be treated with antibiotics, but definitely the main thing is just to be alert and to keep checking on this patient and identify them quicker. The deep infection is going to be the second one. This definitely will be just inside the pocket, maybe an abscess, and the patient will have some systemic effects. Unfortunately, the outcome of this, or the likelihood that that you can save this device, is going to be really slim. And the last one that definitely is not going to involve only us, but as well our neurosurgical colleagues or a spine surgeon, is epidural abscess. So they need to drain this epidural abscess for the patient to improve. The most common location of an infection is a pocket. So as Dr. Patel was mentioning, just make sure that you don't create that big of a pocket. Just create a big enough pocket. Make sure that you use some hemostasis and make sure that you use some, avoid the tissue destruction or too much tissue damage in that area. The most common bacteria is going to be the Staph aureus and the Staph epidermidis. Strep epidermidis. And the risk factors, it's going to depend on the patient and it's going to depend on you. So the one that are going to depend on the patient is if they are smokers, if they have immunosuppression like HIV, or they use steroids chronically, if they are diabetic, or if they're obese. The ones that are going to depend on you is if you create such a big pocket that actually the fluid can accumulate and the blood can accumulate. So it's like a Petri dish for the patient. Then that will increase the risk for infection, tissue damage, too long of a procedure that, of course, hopefully with time, that time is gonna keep decreasing and decreasing. If you leave like some active bleeding before you close the pocket, then that is going to increase the risk of bacterial growth. If you have poor sterile technique, if there's a lot of OR traffic, or there is not adequate OR conditions to perform these procedures in a sterile fashion. And of course, as well, if you forget how to give the appropriate antibiotic, when to give the appropriate antibiotic, and the dose as well. So now hearing this about infection, then what can we do to prevent this? So there's multiple guidelines about this, explaining or how to tackle and how to prevent surgical site infections. Remember that this is a little bit more like a surgical procedure, so definitely there's just way more interest in this by different societies. So the CDC, the World Health Organization, the British societies as well, and the NAC guidelines have as well just described what are the situations, what are the steps that we can take to prevent this. And just to mention a little bit of those guidelines, so just only given the adequate antibiotic for prophylaxis can decrease 50% the risk of wound infection. So just make sure that you use it properly and use the adequate dose. Regarding blood sugar as well, there are some different entities that have done some recommendations. The CDC, they will recommend you to keep the blood sugar perioperatively less than 200. That's going to be the recommendation from them. The American Diabetes Association will tell all of the patients and all of us should have actually an A1C that is going to be less than 7%. However, you just have to be vigilant. If the patient has an A1C higher than 8%, then you may just consider having a discussion with the patient, with the endocrinologist, and then maybe consider postponing this patient when it's better optimized. The American College of Surgeons are a little bit more stringent with the blood sugar levels, and actually what they want is that in the immediate post-op period for the blood sugar to be between 110 and 150. So make sure that the facility that you're working at, they have insulin or they have a way to manage this. Smoking cessation. So starting the week number 4 for the patient that the patient stops smoking, then you can see some benefits on the healing. But ideally, all of the patients should stop smoking for 8 weeks, right? At least 4 weeks, but ideally 8 weeks. Do a smaller incision just to make sure that you have adequate exposure. Don't compromise the exposure just to do like such a tiny incision that you're going to be struggling the whole case, but it's just adequate size. Avoid excessive BOBI because there's going to be a lot of tissue trauma. And then, of course, make sure that you prevent hematoma doing adequate hemostasis. This is going to be as well in all of the NAC guidelines. You're going to have this table, and this is from the last NAC guidelines from January 2022, or the surgical practices. And this is just phenomenal recommendations, and definitely all of us will need to follow them. Just to highlight a couple of them, make sure that you use your antibiotics, make sure that you give it on time. So for NSAID or clindamycin, it's going to be within 30 minutes or an hour of incision, and for vancomycin, it's going to be within an hour to 120 minutes. If you need to remove hair, just make sure that you use some clippers, and you do it immediately before. Okay, so no razors or no other tools or ways to do it. Make sure that you use sterile gowns, sterile globes. You make sure that you use double globes, and make sure that you use either chlorhexidine with alcohol or betadine with alcohol. But the one that most of them recommend the most is chlorhexidine with alcohol. And make sure that you let it dry so you don't start any fires during the procedure. Limit the traffic. Make sure that everyone in the facility knows that you're doing a permanent placement, so they don't keep going in and out. You usually have to remind that to the team that if it is a permanent, we need to put a poster or a sign in the door, so people don't come in and out, as we do with the other procedures. Limit the operative time. Of course, in academic location, maybe a little bit longer, but try to use some strategies to reduce that time. And then the occlusive dressing, apply for at least 24 to 48 hours. After 48 hours, then up to you if you want to live it a little bit longer, but definitely the recommendation is at least for 24 to 48 hours to have that wound covered. And if you need to change it, then make sure that you use sterile technique to change those dressings. All right, so epidural hematoma. So there's a lot of evidence in the anesthesia literature. And actually, when you see the numbers for the anesthesia literature, you say, oh, that's great. And actually, the incidence for the anesthesia epidural and is going to be 1 in 150,000. So that's kind of reassuring. But then when you take a look at the needles, as Dr. Patel mentioned, so the gauge is different, the length is different. Actually, we usually use a 14 gauge because those two needles, they need to be able to feed the cylindrical leads. So it's going to be a bigger needle. And then as well, there's going to be patients with a lot of changes in their spine, right? So some stenosis. So that may increase the risk of epidural hematoma. So what they say is that for neuromodulation, maybe a little bit higher, maybe in the range of 0.01 to 0.3, the incidence of epidural hematoma. Usually, some of the culprits are going to be the blood thinners, right? The anticoagulant. If the patient just decided not to stop the blood thinners, or they just didn't stop long enough. However, just make sure that you understand that it's not only the blood thinners that can give you the epidural hematoma, because 37% of the patients actually can have an epidural hematoma without being taking an antithrombotic therapy. Please take a look at your images. Spinal stenosis actually is just the most common finding when there is an epidural hematoma case or a litigation case. Try to avoid entering into a level with stenosis. You can just go up, either just above of the level, or if there are just so many stenosis that you're not going to be able to drive the lead, see if maybe just at that placement, then the paddle lead could make a little bit more sense. The venous system and the epidural space, unfortunately, plays against our favor. They're really thin wall. They get really distended when there is any type of central canal stenosis. And the fragility of those walls actually increases with age. And guess what? Our main population is going to be really the elderly. So unfortunately, that just plays against us. Other risk factors to take into account are just more patient-related. Going to be platelet count or thrombocytopenias, CKD, liver disease, surgicals carrying out the area of insertion. And that if you don't identify promptly these epidural hematomas, then actually they can lead to permanent sequela in about 0.03% of the times. So what can we do with this epidural hematomas? Of course, first is early identification. Educate the patient to make sure that they know the red flag symptoms. So focal back pain, it's going to be intense back pain. They can have some lumbar radiculitis or some like radicular type of pain. As well, they may have some weakness of the lower extremities if you're putting that in the thoracic area. And as well, they may have some incontinence, some bowel or bladder incontinence. So as soon as they feel these symptoms, they need to immediately go to the emergency department, because time is precious here. And actually, if they will need to get a decompression in less than 12 hours to try to reduce the risk of permanent sequela. So make sure that you coordinate the efforts with the emergency physician, with the radiology department, and as well with the neurosurgery or the spine surgeon that you work with. So ideally, you can have an MRI, but sometimes they take too long. So a CT scan will be fine. The main thing is just to identify if there is a epidural hematoma or not, and to get that evacuated if you find that on the imaging. Sometimes the MRI may be a little bit challenging because some of the devices may not be MRI compatible, or they're going to be MRI conditional, and not all the facilities will be able to have an MRI in the emergency department. Now we're going actually to the opposite. And instead of bleeding, actually we have some thrombotic events. Unfortunately, this patient population, they're ready to start with hypercoagulable because all of them will have chronic pain. So all of them will have a little bit of increase of fibrinogen and factor 7. They may actually have a reduced activity of the fibrinolytic and the prostacyclin, and as well they will have some increased platelet activity. So we will need to, of course, for the ASTRA guidelines and the other anticoagulation guidelines that we need to follow, we need to stop this medication for a high complexity procedure as the spinal cord stimulation or DRG placement. So just be mindful when you do that, because definitely for all the other procedures or all the surgical procedures that the patient are having, they just need to stop it before the procedure, and that's it. They'll just restart it within 12 to 24 hours. However, in our specific case of neuromodulation, actually you need to keep them for a few more days for the trial. Some trials, you do it for a week. Well, hopefully you're doing for less than 10 days to avoid infection as well. But then as well, be mindful that it's going to be, let's say that Plavix, you need to stop it for a week before the trial. And as well, you need to stop it for how many more days? So the patient may go 2 weeks without their anticoagulation. So it's something that we need to make sure that we create some strategies to prevent the thrombotic events. So what to do about it? So always discuss it with the prescribing physician, hematologist, cardiologist, neurologist. Make sure that they are okay with what you're doing. Consider decreasing the trial period. As Dr. Bautista said at the beginning, you mainly need 3 days for the trial. So consider maybe just if you do normally a week and do 72 hours for that trial. Definitely just avoid stopping anticoagulation. The patient has had a DVT within the past 3 months. They had an MI within the past 3 months. And of course, if they have placed any stents, and if it's a drug-eluting stent, then definitely don't do anything after 6 months, or don't stop the blood thinner after 6 months, and ideally no more than a year. And just try to not stop these medications if they have had a stroke for the past 9 months. Dural puncture, so the incidence is low, 0.2 to 3%, but as well, just going to be important that you check on the images. There's a bigger needle, you can create a bigger hole, so try to avoid the spinal stenosis level. Females will have a higher risk. Young patients will have a higher risk than the elderly, so at least this is going to play in our favor that the elderly would have a little bit of less incidence of the post-dural punctural headache. But just make sure that you as well tell this to the patient before the procedure, as well that you as a fellow, if the patient call you or if you see this patient afterwards, that you're able to identify it. So it's going to be a positional headache. Usually it's going to be relief when the patient is supine, but it's just going to increase into when the patient is sitting up or standing up. May have some blurry vision, some tinnitus, some neck pain, and photophobia. So how can we prevent this? So we can review the imaging, use the fluoroscopic imaging, as Dr. Patel was saying. Go back to the trajectory view and the safety view, AP, either contralateral, oblique, or the lateral, just to make sure that you're not going too deep. Once you are inside the epidural space, just avoid turning the tip of the needle too much. The Tuhi has a dull area for a reason, but if you turn it beyond 90 degrees, actually you can transfer that into a sharp object inside the epidural space. Always try to treat it conservatively first, so provide some fluids, caffeine. Resting most of the times is going to resolve itself. It is not recommended to do a prophylactic blood patch for multiple reasons, because not all of the dural punctures will be equal to postural punctural headache, mainly in our population that most of them are elderly. And every time that you put some blood into the epidural space, then again, it's just a reason for the bacteria, if they are around, to grow in that area. And so you create a bigger problem, right? So now you have an infection. So it's something to be mindful about that. So the other option as well, you can do an SPG block that it doesn't violate the dura, or it doesn't go into the neuraxial space, and it's going to be really far away from the lead. So that's something that you could consider before attempting a blood patch. Once the patient just still have symptoms, still not getting better with the conservative management, then you discuss that with the patient and see if that blood patch is going to be indicated for them, just with the risk and benefits, correct? So the risk that you are introducing more devices, you actually may just poke them again, and then just make this problem a little bit worse, and then insert in blood. There's going to be a lot of nutrition for the bacteria if they are around that area. Nerve injury can go up to 2.35%. This as well is going to be important for you to look at the images and to be gentle with your advancement with the needle. If they have some spinal deformity, like, just don't do it in a laminectomy, like go into an interlaminarly when there's no lamina, then definitely that's going to be a recipe for not for success. And then of course, if there is a scoliosis or any other anatomical defect, then it may be a little bit more prevalent, or more, the incidence is going to be a little bit higher. So you can be direct. So you, with the needle, poking a nerve, so that's going to be a direct one, or the surgeon with a lead is just actually directly damaging the nerve. Or it can be as well, not because of the needle, but it can be delayed. So actually the blood or an abscess gets accumulated and compresses the nerve, and that's going to be the delayed one. So take a look at the images for prevention for this nerve injury, and then avoid as well deep sedation or general anesthesia if not done properly. So if you're gonna do it without SSCPs or without neuromonitoring, then just do light sedation. You need to have some type of feedback that you're not going into a nerve, or that you're not you are doing this procedure as safe as possible. So if you're not doing neuromonitoring, then just do light sedation. Don't go for deep sedation. But if you're doing this under general anesthesia, make sure that you have some neuromonitoring that it was mentioned before. All right, well, that's it.
Juan, thank you very much. I think we'll move forward to Dr. Pangetone, who will talk about outcomes, about neuromodulation. And now we're going to have a long evening tonight, so please stay on to see the outcomes or hear about the outcomes. Again, it's very important if you make the case for the patient, if you should approach neuromodulation for the insurance carrier, and also for the public and the lawyers.
And make sure that the sponsors have absolutely.
All right, Jeff, here you go. Thank you.
Thank you all for joining us as we continue through this neuromodulation presentation. I thank all the other presenters. I think we've had a really educational and wonderful presentation thus far. I know we're a little bit behind schedule and I don't want to keep you all too late, so I'm going to try to move through my slides a little bit more quickly. We've touched a little bit on neuromodulation outcomes throughout the presentation, but I just wanted to go into a little bit of a deeper dive. So traditionally, when discussing some of the more earlier forms of stimulation, what's considered now to be tonic stimulation or paresthesia-based stimulation, usually the outcomes from that type of stimulation are presented as a 50-50 proposal, in that 50% of patients could hope to experience 50% of relief in their pain symptoms. However, over the last 10 or 15 years, we've seen significant improvement in the reported outcomes. That has predominantly been related to advancements in development of novel waveforms, and in particular, a shift from this paresthesia-based stimulation to more of a subperception or a non-paresthesia-based stimulation modality. As Dr. Bautista referenced earlier in the presentation, two landmark studies that really laid the foundation for tonic stimulation, traditional spinal cord stimulation, are these studies by North and Kumar we see back from 2005 and 2007. These studies were looking at patients who had persistent spinal pain or failed back surgery syndrome. And the question in the North study was a comparison of spinal cord stimulation versus reoperation in those patients. They followed those patients on an average of 3 years, and they noted that what was defined to be success, which was considered to be 50% pain relief, and patient self-reported satisfaction with their therapy, we see that about 50% of patients were able to achieve that 50% outcome. As opposed to the surgical population, the patients, only 19% of those patients were able to achieve that 50% pain relief threshold or reported satisfaction with their therapy. In the Kumar study, we see that there's a comparison of spinal cord stimulation along with conventional medical management versus the conventional medical management alone. And those patients were followed out to 2 years. And we see that in the spinal cord stimulation population, again, about 50% of patients achieve that 50% pain improvement threshold as compared to the 9% of patients in the conventional medical management population. This is a graphic representation of that, the results from the Kumar study. Again, we see in the black dark columns here that the spinal cord stimulation patients had a higher percentage pain relief as compared to the conventional medical management patients at 1 month, 3 months, and 6 months. That was also when drilled down into VAS scores of leg pain and back pain. We see similar relief in the spinal cord stimulation population, a lot more pronounced in the leg pain group as opposed to the back pain group, but improvement in the spinal cord stimulation group nonetheless, consistent up to 6 months out follow-up. In 2015, we saw a big jump in the paradigm for spinal cord stimulation and a move from paresthesia-based stimulation to this non-paresthesia-based, in this case, high-frequency stimulation in the publication of the SENS-RCT by Dr. Caporal and his group. And they were looking at patients who had chronic intractable back and leg pain. And they compared patients who underwent the high-frequency stimulation versus the traditional spinal cord stimulation. And they followed those patients out to 12 and 24 months. And they saw that to achieve that 50% minimum pain threshold, they were able to achieve that in about 80% of patients at 12 months. And also at 24 months, that held consistent for the back pain group. In the leg pain group as well, 80 to 70% pain of the patients were able to achieve that 50% pain improvement, as compared to the traditional stimulation, where we see that same 50% of patients achieve 50% pain relief, held consistent from the earlier studies that were published and discussed earlier by North and Kumar. There was another follow-up study, a retrospective review of patients who had high-frequency stimulation, followed out to about 9 months. And in that group as well, again, in 2019, Dr. Staus was able to find that about 90% of patients in that group were able to achieve a greater than 50% pain relief. There was also a little bit of a shift in terms of looking at neuromodulation outcomes to look beyond simply pain relief and also focus in on medication changes, improve function, and improve sleep, more of a holistic, overarching view of the patient's recovery and meaningful relief outcomes. Moving along, we see from that study some graphical representations. Again, the high frequency stimulation group, about 80% of patients consistent at 12 and 24 months were able to achieve that 50% threshold of pain relief compared to about 50% in traditional stimulation. Interestingly, what they consider to be remitters were patients who had a pain score of less than 2.5, and almost 70% of patients were able to achieve that threshold of a pain score of less than 2.5 at 12 months and 24 months, as compared to almost about a third of patients in the traditional spinal cord stimulation group. That's looking at back pain. Also looking at leg pain, we see that those outcomes are maintained in the leg pain population as well. Slightly better outcomes in the traditional stimulation group when looking at leg pain as compared to back pain. And then here again, we see another breakdown of 2 years out, looking at pain responder rate, again, greater than 50% pain relief achieved at trial in about almost 90% of patients, and then held out consistent 3 months, 6 months, out to a year, about that 80% range of patients who were able to achieve 50% pain relief. A few years later, there was the Sunburst RCT published by Dr. Deere and his group, looking at the effect of a burst stimulation waveform compared to tonic stimulation for chronic trunk and limb pain. And they compared again that tonic to burst stimulation, followed up to about 2 years. And they see that similar responder rates between burst and tonic, slight advantage to the burst stimulation over the tonic. And then at 1 year, most patients ended up preferring the burst stimulation. Again, that is a non-paresthesia based or sub-perception stimulation modality. Here's the breakdown of the way that that study worked, that there were patients who had the tonic, and then there were the patients who had the burst, and then they switched such that they were able to experience both in a crossover design. This was really trying to establish non-inferiority of the burst stimulation waveform, but they were also able to show superiority of the burst stimulation waveform. And we see here, again, looking at the number of subjects in the group that were able to achieve the improvement in pain of at least 30%. We see about 60% of the group were able to achieve that at minimum 30% pain relief. And then in the tonic stimulation group, we see about 50%. VAS scores in the burst stimulation group also decreased on the order of, from 75 to about 50, and that held consistent out to about 1 year. Moving along to another sub-perception stimulation waveform, what they were looking at here was, if you have higher frequencies, do you need to go all the way up to 10 kilohertz, or what is the effectiveness of 1 kilohertz, 4 kilohertz, 7 kilohertz as compared to one another, as compared to 10 kilohertz? The idea being that if you can achieve equivalent pain relief with a lower frequency, then you may be able to decrease charge burden and prolong the battery life. And here we see that they were able to achieve about 50% pain relief across all these frequencies, followed out to 2 years, followed up again in 2020 by Dr. North and his group. Again, about patients were able to achieve greater than 50% pain relief in the sub-perception, as well as the super perception or the paresthesia-based groups. Here's just another graphical representation of that. We see significant decreases in the pain scores from 7 to about 2, held consistent out to 1 year. Then a significant portion of the population here achieving greater than 50% pain reduction with the sub-perception stimulation waveform. Finally, another novel waveform published most recently, 2021, this differential target multiplex stimulation waveform. This was being compared to traditional spinal cord stimulation, looking at, again, chronic low back and leg pain, and in particular, trying to improve the efficacy of spinal cord stimulation for back pain. And we see that in back pain in particular, there was a greater than 80% relief was able to be achieved in 69% of the population with that DTM stimulation waveform, as compared to only 35% in the traditional spinal cord stimulation waveform. Finally, we talked a lot about thus far DRG throughout this presentation, and I just wanted to include this slide to show the comparison of DRG to spinal cord stimulation in the treatment of CRPS. And we see that DRG and spinal cord stimulation were pretty equally effective for CRPS as shown in the ACCURATE study at 1 month. But as you kind of drift out and follow out to a year, the DRG stimulation group really held their outcomes, whereas the spinal cord stimulation outcomes started to decrease a little bit. And there's a lot of conversation on habituation and the ability to maintain therapeutic efficacy when comparing DRG stimulation to spinal cord stimulation. So that was a little bit of a whirlwind, but I think in summary, the point that we're trying to make across with these slides, looking at neuromodulation outcomes, is that we've really come a long way. Where almost 15 years ago, we would be happy with 50% of patients achieving 50% pain relief, with the novel waveforms, we're able to achieve almost 80% of patients achieving at least 50% pain relief, and often greater than that. We saw that a lot of patients are able to achieve pain scores less than 2, going into what we would consider pain remission, having significantly improved outcomes. And then we saw also with the development of DRG stimulation that therapeutic efficacy can be maintained on a long-term basis. In the future, ideally, we'd be able to see some more independently funded studies or databases, potentially registries to track outcomes further out beyond this 2 or 3 year outcome that we currently have for a lot of our spinal cord stimulation data. And then ideally also looking at improvements in study design and tracking of meaningful patient outcomes, more functional outcomes, not just looking solely at pain scores or percentage pain relief. I did want to address one question that was included in the chat. It seems like a very relevant topic. There's a paper published in JAMA comparing burst stimulation to placebo stimulation. And there's a lot of issues with that study, but ultimately their conclusion was that there wasn't a big difference between what they consider to be burst stimulation to placebo stimulation when looking at ODI scores. A couple issues with the study. Number one, they didn't really define what placebo stimulation was. So the assumption is that no stimulation or ineffective stimulation, but it's, that's an assumption that wasn't really clarified. If it was tonic stimulation, for example, then there would make sense that there wasn't a lot of difference between a tonic stimulation waveform and a burst waveform, but that's not what's implied by the conclusion. So that requires a little bit of clarification. In addition, there was the way that the burst stimulation was performed. At trial, there was paresthesia-based tonic stimulation. At implant, there was this burst waveform that isn't truly, the industry-sponsored or industry-approved burst, and it's not really the burst that's used by another industry company. So it's this kind of in-between stimulation that doesn't really have any other evidence to support it. So it's kind of like an outlier. It's kind of comparing apples and oranges between the trial and the implant. And then even when looking at the implant, that burst stimulation waveform isn't one that's clinically used. So hard to interpret the results of that when considering those factors. The Spine Intervention Society and Dr. Hagedorn both put out kind of reviews that describe some of the other issues with relation to that particular study. So I'd refer you to that for more detail. But in general, I think the outcomes are strong from neuromodulation as exhibited through these well-performed large studies. And so I'm excited to see the future where further indications can be utilized and to improve access to patients for neuromodulation.
Thank you very much for addressing this question, and the paper was published in JAMA. And again, following you, for the audience, feel free to reach out to the different pain societies and also the experts in the field who are commenting on the paper or will be or in preparation providing comments how to address the result. I think we are done with our time, and I really appreciate everyone staying on. I really appreciate my 4 speakers who did an excellent job. Again, it's a very broad topic, and you got it done in 90 minutes, to our next generation pain physicians. So to embark and taking on the field of neuromodulation, which I think has still a great future. There's more to come, and it can already help a lot of patients, which we couldn't really treat in the past. I think the last thing I would like to do is to invite everyone back for our next hot topic webinar, which will be on Tuesday, March the 7th. Again, Tuesday, March the 7th. And I think it's a very important topic, and that will focus on your future job search, practice evaluations, and having a successful practice. Again, those are things, honestly, you can't really read in a journal or in a book chapter. So please join us back on March 7th. And I wish everyone a happy new year, a good start, and have a good evening. Thank you. Bye-bye.